Hello, everyone, and welcome to McGill Cares webcast series supporting family and informal caregivers. I'm Claire Webster, a former caregiver, certified dementia care consultant, and founder of McGill University's Dementia Education Program. I work with a dynamic team of leading healthcare professionals to oversee the program, who include Dr. José Moret from the Division of Geriatric Medicine and Dr. Serge Gauthier, Professor Emeritus, formerly of the McGill University Research Centre for Studies in Aging. McGill Cares is supported by the Amelia Saputo Community Outreach for Dementia Care. The McGill Dementia Education Program offers a comprehensive range of free resources to educate and support persons living with dementia, family and informal caregivers, healthcare professionals, medical students, and the public at large. One of our most important resources is the Dementia Companion Guide, which can be downloaded for free. It's currently available in 8 different languages, and printed copies can be obtained on Amazon at a cost of $20 per copy, and all proceeds support our program. So today we have a very important topic, which is healthy brain aging. And I have the great pleasure of having Dr. Serge Gauthier as my guest, my wonderful colleague. Dr. Gauthier is a clinical neurologist specializing in the development of new tools for diagnosis and treatment for people living with Alzheimer's disease. He was the director of the McGill University Research Centre for Studies in Aging from 1986 to 1997. Dr. Gauthier is the academic co-lead for the Dementia Education Program and Professor Emeritus, Neurology and Psychiatry at McGill University. His accomplishments led him to being appointed to the Order of Canada in 2014 and the National Order of Québec in 2017. Today, Dr. Gauthier will provide an overview of recent research that shows how we can maintain our brain health as we age. Cette web émission est également disponible en français. Welcome to McGill Cares, Dr. Gauthier.
Thank you very much, Claire.
So we're going to be exploring a very important topic that interests many people. I think that unfortunately, dementia is one of the diseases that is most feared right now in our society, and very much looking forward to hearing the latest research on how to hopefully prevent having it.
Super. So thank you, Claire, for allowing me to use a few slides to introduce the topic to our viewers. I will also make suggestions for those who are keen to get involved with prevention. I'll give you some secret phone numbers and names and email addresses so you can join research on this field. This is the content of my few minutes of remarks using slides. The natural history of age-associated cognitive decline. What does it look like over time? We're going to use Alzheimer's disease as a framework, but our discussion today is really about prevention of dementia. But we can use some milestones in what happens to the brain as we get older before dementia. A few findings from observational studies, one of them being at McGill, and people can join. 2 examples of results from interventional studies, one in Finland and one in Canada. What can you do if you get involved? And there is indeed in Montreal a program at EPIC, which I will talk about, that you can join. And final words on prevention. Is it for the population as a whole? Yes. But is it applicable to individuals like the listeners today? So yes and yes. So first part is the natural history. So let's use some examples that you will find in the guide that Claire mentioned earlier. This is a lady who's doing multitasking. She's on the phone, she's paying her bills, she made tea, everything is well. But now if we use the framework of what happens over time with Alzheimer's disease, we'll use some landmarks. So this is a useful diagram when we explain brain aging and when we talk to families and persons living with dementia. So bear with me just for a second as I explain it. So you have on the left some mood changes that come with age, and there's a measure that you can use. I'll give you the web page. You can actually check how cranky you are, or your spouse or friend. Then over time, we're talking about 5 to 10 years now, there's a subtle change in memory, and we have a name for that. And then there's a not so subtle change in your ability to function at home, and that is moving into the field of dementia. Uh, we won't discuss moderate to severe dementia, but just note that behavior that changes that are major, such as not recognizing your spouse, your house, and being restless at night, occur usually later in the course of Alzheimer's disease. But some types of dementia can occur earlier. So this lady who was multitasking at home can have, like all of us, some lapses. So now she's forgetting her password at the bank. Okay, but she knows where to find the password. It's in her agenda. At least it is in mine. So we have these little lapses, like what's your this person's name and what's my phone number I want to call, or somebody asks you what's your phone number, and you have a pause. That's normal. As we get older, there's a slight delay in reaction time to answer questions, to remember things, but we know where the answer is. We can retrieve it. So there's a name for that. We call it subjective cognitive decline. So that's only you who is worried, nobody else. And if we test you with a paper and pencil, you're normal. It's just normal aging. Bon. Now, there could be a point where you forget things that are significant enough that your family or friend or coworkers are noticing there's a change. So it's no longer just subjective. Somebody else is worried, and you may be moving into an era of brain aging that is measurable with cognitive tests, but it's not yet interfering with your daily life in a significant way. So this lady who had maybe she's forgotten to pick up the kids at daycare or pay her a bill, or maybe she forgot to take her pills just once or twice. It happens to all of us. She's moving into a phase we now call mild behavioral impairment because she may be worried about these changes. She may be a bit defensive when she was reminded about this or that. So there's actually a name that's been coined by a team led by a psychiatrist in Calgary, Dr. Zainar Ismail, MBI. And there's a checklist. You can go online and find it, MBIC, and you can check if you have some features that suggest there's a change in your mood that is not explained by depression or other factors. We don't know yet if this age-related change in mood and behavior is a premonitory feature of Alzheimer. I think it's just noise in the background of our lives, going through pandemic and interest rates going up, and we're just alive. And so some days we're cranky. Okay, now you may also have mild cognitive impairment. So this is a term that's been used in the medical literature for about 10 years. It's also used in clinics. So you may go with someone, you see a doctor, and this is a topic we deal with in another McGill Care, the diagnosis of MCI and early dementia. Just to say that this mild cognitive impairment is not automatically annunciating future dementia. It could be just a reversible state of being less able to focus, especially if you do a paper and pencil test and you get a lower score than expected. It may be just because you take the pills that are clouding your mind a bit, or you're depressed a little bit, or you take too much alcohol, whatever. You may be hard hearing. Lots of things can explain mild behavioral impairment, mild cognitive impairment rather than dementia. Okay, this is one of the tests that is used mostly around the world. It was designed in Montreal by at the time, a young neurologist, and it's called the MoCA test, Montreal Cognitive Assessment. Dr. Nasreddin is the name. He works on the South Shore. I'm saying this because you could go online and try the test just to see how easy it is. And don't worry, we have alternative versions when we actually test you online or in person. And this is the first message I have for you. If you want to join a study where we can evaluate the MoCA test online, can it be used for screening? So you could contact the team, the MoCA team, using the info@mocatest.org. Okay, and you can sign up and you will help validating this instrument for remote use. This would be particularly useful for people living in rural regions or people who have difficulty getting out for physical reasons, whatever. Okay, now this lady, we keep monitoring. She's having need for help. So she's moving into a stage of a mild dementia, which we will not discuss today. But you see, she needs assistance from someone. The the old term dementia is still used worldwide, but in Quebec, there's an attempt to use a new term called neurocognitive disorder major. MCI would be minor neurocognitive disorder, and dementia would be major neurocognitive disorder. So if you see a doctor's report, you may see those terms, major, minor neurocognitive disorders. Okay, and this is now moving into more need for help on daily life. So to summarize this natural history of brain aging, there are so-called prodromal symptoms, not specific, many years. We're talking about 5 to 10 years minimum before you actually have Alzheimer's disease, dementia. And the names we put on for research purpose are subjective cognitive decline, mild cognitive impairment, and a new one called mild behavioral impairment. And not all persons who have this will progress to dementia, but it's a very good incentive for you to use all preventive strategies available. And that's why you're listening to me today. And the doctors are using instruments to fine-tune how to measure memory when it's very subtle impairment. The MoCA, we're working on it still. MBIC, the scale developed, and so on. So there's active work going on worldwide to measure subtle changes as you get older. So examples of observational studies about brain aging, and we're getting now into what can you do about brain aging preventively. So first, mise en contexte. So what are the changes in your brain as you get older? So long before you have cognitive symptoms such as MCI, there may be changes in the brain chemistry, in the cells, and I will show you examples of that long before you have dementia. 10, 20 years before. And the way we understand brain aging and Alzheimer nowadays is you would have this beta amyloid buildup in the brain 20 years minimum before you get any symptoms. And even with a lot of beta amyloid in your brain, you may never have symptoms. It's not sufficient to cause dementia. Because you need also in the middle NFT, it's a change within the nerve cells. It's like the skeleton within the nerve cell is twisting on itself, so it tangles. And this is another protein that's abnormal with age called tau, the Greek letter tau. And there is a microglial activation at some point in the 20 years before symptoms. And this is one of the specialties here at McGill. We're trying to understand how brain neuroinflammation plays a role, and can we prevent that with drugs for arthritis, for instance. And finally, as you get closer to symptoms, the brain starts to be smaller, and we can see that with special tests. So this is a diagram from Dr. Pedro Rosaneto, my work partner at the Center on Aging, to make the point that there are multiple factors at play as you get older, and we can intervene with multiple factors at the same time, possibly. So unhealthy lifestyles, I'll come back to that in 2 minutes. Impaired cerebrovascular function, that's important. What's good for the heart is good for the brain. In other words, if you can prevent heart attacks and strokes, you prevent dementia. This was very well demonstrated in Ontario, where they have a very aggressive plan to prevent stroke, and it's before the pandemic at least, affecting the number of people with dementia. So again, what's good for the heart is good for the brain. Clearance of the abnormal proteins, it's not something we can change right now, but indeed, theoretically, if you have this buildup of a beta amyloid in your brain and there's a way to flush it down your spinal fluid more efficiently, that would be one way to prevent brain aging. Inflammatory response, I mentioned already. I'll give you a hint. It's a discovery by a Vancouver doctor 30 years ago that if you have arthritis and you take NSAIDs, chronic medications for arthritis, you have a much reduced risk of dementia. And it's because it would affect this inflammatory component of brain aging. Genetics, you cannot change your parents, but one good news from all the research being done now, if you inherit only from one side of the family a gene called ApoE4, lifestyle changes and the ensemble of prevention strategies we have is sufficient to offset that genetic risk you have. If you have double 4, both sides of the family gave you that increased risk gene, that's a different story. And maybe you'll need a medicine early on in your life to prevent the amyloid buildup. And comorbidities means as you get older, you have kidney problems and heart problems and arthritis and aches and pains and decreased hearing. So other things happen with life. And if you help hearing, vision, if you have a good heart, you fix the irregular heartbeat, you also help brain aging. So multiple factors at play. And these are not just additive, they're synergistic. They amplify each other. In other words, if you can help preventively one or two or three factors, it's better than just one. In other words, if you just exercise, it's good for the heart and the brain. But if you don't do anything else, it's not sufficient. You should do multiple things at the same time. Now, at McGill, we have a cohort. It's been about 7-8 years running. It's called TRIAD, T-R-I-A-D. It's out of the McGill Center for Studies in Aging. These are volunteers like you. No symptoms, mild symptoms suggestive of a mild cognitive impairment or mild dementia. You're all welcome to join, and you get a total body checkup. And your brain, you get scans of the brain, you get blood and spinal fluid examination, and you contribute to research. We already have findings that there's a blood test that can help document what's going on in your brain. And this is something that will change the way we do clinical assessments in the clinic in the near future. So just call Jenna, 761-6131, extension 6321. And she will see where you fit in the program. This is an example of a volunteer in that cohort who had mild dementia, and he had all the scans and the spinal fluid exam and the bloods. And guess what? His top scan at the top, there's nothing red in it. There's no amyloid. So he has what we thought was Alzheimer dementia, but there's no amyloid in his brain. So he does not have Alzheimer. He has something else. And the middle scan with the red shows the tau buildup. So he has a new condition. We're not sure what to call it yet, where tau protein is the main factor at play. So this man does not need an anti-amyloid therapy. He needs an anti-tau therapy. So we can focus on the needs of individuals at whatever stage they are in their course of brain aging. The blood test I mentioned to you that was partly born out of the work done at McGill. This is an example of what we find. These are the Swedish partners we work with. You see on the left in the red box, in blue, the levels of the blood levels of p-tau, phospho-tau in the blood, which is equivalent to what we see on the scan in the brain. And this will probably mean we can use this test very soon in our clinics. So it's possible that if you're 60-year-old, as part of your workup for your risk of future Alzheimer in 10 or 15 years, you will now get a blood test for ApoE4 and for this p-tau isoform, which is work done here at McGill. So a couple of examples of what epidemiology, observation of large populations, can tell us. First, the big article that everybody quotes is from what they call the Lancet Commission. This is the article you want to read. It's updated every 5 years or so. This is the latest one. It lists potentially modifiable factors. And if you run through the list, there's 12 of them. Diabetes, no surprise, high blood pressure. So many of these risk factors are for the heart, but also for the brain. So again, what's good for the heart is good for the brain. If you have diabetes, treat it well. If you have high blood pressure, especially in midlife, age 40 to 60, treat it well. Take your pills if you need them. Obesity at midlife, so you need to lose a bit of weight. Physical inactivity, which is the biggest problem we have in Canada right now. Depression may be a prodromal factor, so it's considered a somewhat a risk factor. Smoking, of course, not good for the heart, not good for the brain. Low education, it's not such an issue in Canada, but it is in rural regions of Sri Lanka, China, and to some degree, northern communities in Canada. Hearing loss is a new one. This is important. So if you have impaired hearing, fix it because it's a part of brain aging. Traumatic head injury, you know about rugby players, football players who get repeated head injuries. It adds up and you get accelerated brain aging. High alcohol. So that's a current debate. How much alcohol is good? It should be 1 glass a day. One normal glass, not a big glass. Social isolation. Yep, important. And air pollution is a new one. It's not so bad in Canada right now. Look at India and China, and that is bad. But it's a new one that to watch for. Okay, some examples of smaller studies that you can do. This is a US one. It's done in a city called Framingham. And no surprise, they find that if you have diabetes and you're not active physically and you're obese, the combination of the three will increase the risk of dementia later. So you should fix all three. Treat the diabetes, get physically active, and lose weight. Okay. This is a study in China. 30,000 people were monitored over 10 years. And if you have at least 3 good habits out of 7 or 6, you reduce the rate of cognitive decline. Your memory is better after 10 years than if you have only 1 or none of these good habits. And there's an article in Press Now. It also shows that if you have more than 3 of these good habits, you also decrease the risk of dementia. So what are the good habits to have? A healthy diet, Chinese style. Yesterday, there was a publication I shared with Claire about Mediterranean style diet in the UK, in England, which is closer to our habits. And apparently tea drinking is good in some countries, especially in China and UK. I'm not sure about Canada. Regular physical exercise. You keep hearing this, and you do have to pay attention. It is the single most factor that is protective, but you need to get out. So thank God I have a dog, and so does Claire, and it keeps us active. Active social contact. So it means if you read a book, it's better if you share an impression about it with a book club. If you watch a movie, it's better if you are with other people to share what you think about the movie. So social interaction is as important as the actual thing you're doing. Cognitive activities, that could be anything, playing mahjong for the Chinese, but it could be playing bridge for us and so on. No smoking, no alcohol. No alcohol is a bit harsh. That's the way they decided to do it in China. But for us, 1 glass a day on average would be adequate. And the good news, as I said earlier, if you have inherited from one side of the family a risk gene, these good habits offset this genetic effect. This has been found also in other cohorts in other countries. So to summarize this part, the cohorts we have, such as at McGill, allow us to define the brain aging using measures of amyloid tau and neurodegeneration, and there's a blood test that may be the equivalent very soon. You can join the cohort if you're interested. We will move progressively into intervention studies depending on your needs. And observational studies, such as mentioned in the UK, China, and the US, clearly show there are protective factors that you can build on and risk factors you can avoid. They will, of course, differ between countries, and it may be different if you're 40 versus 80-year-old. So you need to be adapt your strategy based on where you are and how old you are. So intervention studies, just 2 words about what has been done around the world. It's quite impressive. The pioneer work was done in Finland by a young lady named Mia Kivipelto. And what she did is show that if you have a group of volunteers, like you are, listeners, and you randomize people to usual care, see your doctor once a year, or you have a package of nutritionists making sure you eat good, especially in Finland. You have to fish 3 times a day instead of just once. A physical exercise with a coach so you don't get a heart attack. cognitive training, preferably with a small group of people, and monitor the heart, vascular risk control. What happens after 2 years is everybody got better. But those who were on the special package were even better for cognition, especially executive ability to make decisions, processing speed. So things that are important in daily life, and memory. And if you keep following these people beyond the 2 years of intensive training, the improvement is maintained, and there's less risk of a heart attack. There's less risk of losing functional autonomy, less risk of chronic disease. So there's a benefit not just on memory, but on the person as a whole. If you have this combination of a good diet, physical exercise, cognitive stimulation, preferably with a group. So you see where I'm going? Yeah. And now they're adding something new to this concept, a medication, an old one for diabetes. So let's say you have a group of people that are aging, but they're slightly more at risk of accelerated aging. You can decide how you define that risk. And then you repurpose an old drug, such as metformin, which can improve the ability of the brain to use glucose and oxygen and make yourself more efficient. Even if you don't have diabetes, they're going to see if it makes a difference. It may not make a difference, but this is a repurposing of an old drug, well known for its safety in non-diabetic people. In Canada, we have CAN Thumbs Up, and the work has been progressing despite the pandemic. This is the name of the study in Canada called Synergic, because it's a combination, a synergy of physical exercises, paying attention to your gait in particular, and cognition. And the early results are encouraging. Compared to people usual care, there's an improvement in memory tests using ADAS-Cog, which is a more difficult memory test than the MoCA. They also tried vitamin D as a supplement. It made no difference. Vitamin D, if you're not vitamin D deficient, did not add a benefit to the memory training and the physical exercise. And what you can do now in Montreal is join the program at EPIC, which is part of the Institut de Cardiologie. They have a Synergic-like program. So if you sign up, you get a total body checkup for your memory and everything else, and you are randomly allocated to usual care, which is very good care, and the package of physical exercise, cognitive training, and careful watch of your vascular risk factors. So you can sign up. Just join louis.berer. It's spelled BHERER at universitémontréal.ca, or just call up EPIC. So to finish, the perspective is that what we're discussing now for the populations as a whole or for individuals? Well, it's both. And as we wrote in the World Alzheimer Reports 2021-2022, which is available no charge online, these are big documents, but they're available. There's one chapter in the report 2022, which I will highlight. It's chapter 23, Strategies Towards Dementia Risk Reduction. So it's a complement to what we're talking about today. And it's written by some of the people I mentioned, like Kivi Pelto, the one who created the finger program, and a local physician, Dr. Koza, about managing your individual heart risk factors. So you get a blend of population strategies and individual, based on individual needs strategy. And this is a time to be optimistic about prevention. We know that the current generation of baby boomers is at lesser risk of dementia compared to our grandparents. That's a given. But we want to do even better, if possible. Delay dementia by 5 to 10 years is realistic for us. We're very fortunate to take advantage of all the knowledge gained in the past 30 years. But we want this for our children and grandchildren and for the future, because as we live longer as a population, we have these risks of brain aging and dementia, and we need to pay attention to our brain as much as we do to our heart. And it just happens. What's good for the heart is good for the brain. Okay, Claire, take it over.
Thank you so much, Dr. Gauthier. It's the first time I hear you give this presentation, and it was just fascinating to listen. And I have a list of questions for you. So first of all, at the beginning, you talked about subjective normal decline, okay? And that is that whole, when you mentioned the word pausing, I'm 55 and I find myself oftentimes pausing, right? I want to say something, or I walk into a room and go, what was I supposed to do? Or, I also have friends who say, I meant to say this word, but another word came out, okay?
Yep.
So
Yep.
could you just expand a bit on subjective normal decline? Because it is scary.
It's scary, but once you know it's part of normal aging, you you relax, and you can actually take advantage of the pause to give perhaps a clearer answer. If you see the shows on TV, if there's the champion at many of these shows will pause on purpose to really think through the answer and then give the right answer. And yes, we do mix words. It's funny when we talk someone, we name someone the name of our dog. Yes, or our dogs, we mix them up. That's all normal. The simplest way to explain that is the hard disk is getting full. We do have a finite amount of nerve cells and synapse connections in the memory parts of the brain, and it gets busy. Also, alcohol will interfere. Some medicines we take for the stomach, for acidity, or pills we take for the bladder to reduce the frequency going to the bathroom. Anticholinergic side effects, they also interfere with our memory. So it's partly normal aging, partly perhaps things we do that we can modify.
So because you mentioned, there are other factors, like it could be medication, it could be something physical going on. Could you just really emphasize the importance of, if somebody is concerned, to seek a diagnosis? Because a lot of times people will say, why bother? There's no cure. So why bother getting a diagnosis?
Well, it's important because there are treatable factors readily, but even at 55, 65, 85, the family doctor may need 2 visits to sort it out, but there are many reversible factors. And once that's done, okay, it's just aging, and we'll see how it goes. Many people have natural resilience. It's a term we use now. It's not explained well biochemically, but we do have people in their 90s who have plaques and tangles in their brain. They have Alzheimer, but they have no symptoms. So there are protective factors that we're trying to understand. And I think we're going to learn a lot from research in people over 90 and over 100. There's more and more of them who have no significant brain aging manifested in their daily life. What's protecting them? And the best we can say for now is they tend to be people who are socially active. That they were good for their heart, and they feel useful. So there's more to come on that, especially as our audiences will grow older, because I do expect our audiences over the years, Claire, the baby boomers we now have in our triad program, we will age together, and the protective factors will change. We all already know over age 90, amyloid is not so important. There's another protein at play. It doesn't have a name yet, just a number, TDP43. But we're going to study that and see if we can help.
So the other thing you talked about was having deposits of beta amyloid that appear 20 years prior. Okay, how do we know that we would have it? Like, can we be tested for that? Like, how do we know that we would have those deposits?
I don't think you should be tested for that because it's not a predictor of having dementia. As I said, many people over age 90 have their head full of amyloid and no symptoms. It's a different story if you're younger than 40. Then that means you're probably carrying a gene that causing the amyloid buildup before age 40, and you probably have familial Alzheimer disease, and these are rare families, and we know them well in Quebec and Ontario thanks to a program run by Dr. Rosaneto. So over age 60, when people go for their future checkup for risk, we will not measure amyloid buildup. We will rather measure tau protein buildup, because tau protein, p-tau, the discovery we made with the cohort at McGill, with the help of the Swedish investigators, is a better indicator of brain aging.
So the other question I had is when you showed that amazing chart from Dr. Rosanetto about the different, I guess, not
Factors, I
on
believe.
this stuff, but that chart. So you talked about clearance, okay? Clearance of also of the clearance of beta amyloid deposits. So how is clearance done?
It's the natural way of the brain to have, especially when you sleep, during a REM sleep, you have these waste products of brain activity literally flushed down the spinal fluid into your blood, and out it goes in your liver and kidney. So that allows me to talk about sleep. It's one of the important factors in brain aging that is being studied. We're lucky in Montreal to have a very high level team at the institute at the old Sacré-Cœur Hospital. Not sure what it's called now, but there is a team there that has worked with us about sleep changes and memory decline, and it's now a field of interest at the Douglas as well. Just remember, those who are listening, that sleep is important, especially a REM, the period of sleep when you dream. Try to stay away from sleeping pills. Try to get natural sleep, but try to get your 6 to 8 hours every night. Because apparently the clearance, since that's your question, Claire, occurs
exactly.
during that sleep period. Yeah.
So, and then the other question I had was about the genetic risk factor. So the ApoE4. You said that if you only had, I guess, one set, there's a way to offset it.
Yeah.
Well, how do you offset it?
It's a combination of things we talked about. So if you do exercise and you're active and you feel useful and you watch your general health, it does offset that one side of the family risk. And if you have both sides, which is rare, it's 3% of the population, so it's still a significant amount of people. There's a different program for that. And there's an old drug developed by Dr. Bellini at Neurochem way back 20 years ago that's being repurposed for these people, double 4. And we'll have results in a year. It's a pill, it's not an injection. And this may be specific for that higher risk, genetically speaking, population.
Okay, so one of my last questions is about alcohol. So, when you look at all the genetic risk factors combined, first of all, I'm half Finnish, right? I come from, a generation of people that love their vodka, or, like watch my mom, so somebody that is physically active, okay? We work out every single day. We keep ourselves socially stimulated. Our weight is under control. We're managing our high blood pressure, cholesterol, right? But now here comes the glass of wine. And I think, yes, when we say you should only have one glass of wine, but realistically, people are not having one glass of wine, right? If you're having a bottle of wine with dinner, you're sharing the bottle. If you're with friends on the weekend, you're, having more than one glass of wine. So what is the risk factor for somebody that is doing everything else okay, but is drinking a little bit more than one glass a day?
It's relative risk. This is a topic of interest because 2-3 weeks ago, there was here in Montreal, and I think most of Canada, this debate about whether the current norms of alcohol consumption should be changed to like 0 or 1 glass. And in the field of Alzheimer, it's been known for many years that a glass of red wine, 1 glass a day, on average, is protective compared to 0 and compared to too much, which would be more than 3 a day. Now it's changing the debate now to alcohol in general. And my understanding of the debate is if you have special risks such as colonic cancer, high risk, or specific other conditions where alcohol is important as a trigger, you should avoid alcohol as much as possible. But for the average person, like you mentioned, 1 glass a day on average. So it could be 2 glass, 3 glass on weekends. Obviously, it's average. And it's always relative risk also.
And what I find fascinating when we talk about, healthy brains, why is it that when we go for our annual physical checkup, the doctor will check our eyes, our ears, our heart, but we don't ever have a brain checkup? I mean, is that something that would be a wave of the future? Like, because we never have a brain checkup. I mean, at least I never had a brain checkup.
Indeed, it's something that needs to be done. There are different ways proposed to do that. One is online. So there are people at McGill, Dr. Grover in particular, developing a website. I tried it last night. Actually, it works very well. You just go online. They ask about your risk, your protective factors, different things, and then they give you an estimate of your risk and what you should do about it. So that's the simplest thing. You just have a reliable website. You can also have something new called brain health clinics. It's a concept proposed in Europe. And we're going to study this in Canada, whether it's applicable. It would be the same as going for a heart attack prevention clinic. Mm-hmm. So can you do at the same time an assessment of heart and brain? That would be my suggestion because it's more cost effective from a societal perspective. And it's also linked. It's the same risks, more or less, when you're in midlife. So it's coming, Claire. It will be called Brain Health Clinics. It's something we want to pioneer together at McGill. With a new program that is under development, but it's a concept also proposed in Europe on a large scale, brain health clinics, which are mostly preventive. And this perhaps will answer some of the other questions from our audience.
Dr. Gauthier, thank you so much for taking the time to be with us today. And all of the links and research opportunities that you mentioned will be available on our trusted resources section at mcgill.ca/dementia.
Super. Merci.
So this webcast is an initiative of the McGill Dementia Education Program, which is funded by private donations. If you would like to make a contribution to our program, please visit us at mcgill.ca/dementia. And if you would like to join our mailing list to be notified about upcoming episodes of McGill Cares, as well as other important programs and resources from us, you can email us at dementia@mcgill.ca. Thank you for watching.